after Amit's wonderful talk is one other important entity which we don't discuss much. And we believe this is important that we start recognizing disease entity called eosinophilic esophagitis and lymphocytic esophagitis. I'll talk more about eosinophilic esophagitis because this disease is much more recognized compared to lymphocytic. Lymphocytic esophagitis is still evolving and we don't have much data. So most of my talk will base upon eosinophilic esophagitis. I have no conflict of interest, but a couple of things I want to say that I'm no expert in eosinophilic esophagitis and have no major work except for one article which we did. And also, I want to acknowledge the three guys, three very smart our students of ours, Ansuman, Avinav, and Srikant, which helped me in making this presentation. So let me start with a case. We have a colleague of ours, a 32 years old person, who came to us one fine afternoon on Saturday with a complaint of acute food bolus infection for 1 hour. And he came to office. He also had a chest pain. He has one similar episode about 6 months back and was resolved within a few minutes. He had no dysphagia in between, no chest pain, and he had a normal appetite. We did endoscopy about the food bolus infection. We found that certainly the food bolus, which we removed, which we pushed through endoscope, but we found these ring-like lesions in the esophagus. And we thought clinically, or I have thought clinically, that this is most likely a eosinophilic esophagitis. And he did a biopsy from this, and so that he had multiple eosinophils in his biopsies, and he was diagnosed to have eosinophilic esophagitis. So we treated him, and we'll come back to that, what we treated him. But before that, let me talk first about the disease entity. So what are eosinophils in GI tract? Normally, in normal situation, in the esophagus, there are no eosinophils. In the esophagus, there are no eosinophils. If you go to stomach, it is about 2 to 10 per high power field. In duodenum, slightly more, and colon, slightly more. So in esophagus, there are no eosinophils in normally, and if counts are more than 15 eosinophils per high power field, it is called gastrointestinal, or it is called eosinophilic esophagitis. So there are a number of conditions which lead to esophageal eosinophilia, the most common being the eosinophilic esophagitis. Nevertheless, the patient with GERD do have high eosinophil counts. Other disorders like celiac disease, Crohn's disease, echinacea cardia, pemphigus, and graft-versus-host disease do have eosinophilic infiltration in the esophagus. And also one disease entity is called hypereosinophilic syndrome. They can have eosinophilic infiltration anywhere in the body, and multiple organs may be affected. So there are numerous causes of esophageal eosinophilia. So this is the disease entity called EOE, which was first recognized in 1976. Since 1990 is recognized much better, but most research have been done in North America and Switzerland, because the two groups have been working extensively in this group, in this disease entity. And now by now, this disease is seen all over the world. And if you look at interest in this disease, the number of publications have been increasing over time, both from every continent of the world. A number of almost 300 to 400 papers are published every year in this subject. So how common is this disease? It was first thought to be a disease of children, and it's seen mainly by pediatricians. But later on, it was about 15 years or so, a lot of adult, gastroenterologists also see this disease entity. If this disease occurs all across the age group, starting from less than 5 years, even 2 years of age, this disease can be seen as high as 60 or 70 years of age seen. It's more common in males compared to females. So one must remember that disease is not uncommon. And I reviewed, this is a casual review of Indian literature, and we could find there are 6 or 7 reports, mostly case reports and case series, describing either single case or multiple cases of eosinophilic esophagitis. And there's one prospective study which we did. Uh, we'll discuss that in a minute time. We all see, once you talk to your colleagues, we all see patients with eosinophilic esophagitis once in a while. But again, we don't have greatly published data on this entity. Therefore, we're interested to know that what happens. Do we really have this disease entity in our population? So what we did, we looked at a patient with GERD, and in them, we screened for eosinophilic esophagitis. So in this study, we looked at 185 consecutive patients with a GERD, and we found 6 of them, 3.2% of GERD patients had evidence of eosinophilic esophagitis. And once we looked at predictors, what are the predictors of when can you suspect that they have a eosinophilic esophagitis? Then we found that those who have history of allergy, or if they didn't respond to PPI, they were the predictors of presence of EOE in those patients who have a GERD. So one must remember that in our country, 10% of the population have a GERD. And if you look at of the 10%, even 3% of them are eosinophilic esophagitis, then we can see in a country like ours, which is about 130 billion people, we will have a large number of patients with eosinophilic, which are not recognized, unfortunately. So what is eosinophils? So normally that eosinophils will infiltrate in response to some kind of antigenic or allergic stimuli. And we know eosinophil is a very important cell which have multiple functions, including it secretes a lot of proteins, major being major basic protein, and multiple others proteins. It also activates some number of cytokines and also neurotransmitters. All of these ultimately, at the site of their infiltration, leads to destruction of that particular antigen, and as they do that, they also destroy the infiltrating tissue. So what really happens in this condition? So there is some intraliminar allergen exposure, and here the most common, most likely the food antigen which we eat, that's act as antigen in some patients who have a susceptibility to this disorder. That leads to mucosal production of eosinophilic chemoattractants in response to these antigens. Therefore, the eosinophils are attracted, or they are invited from bone marrow. From bone marrow, they come to circulation, and then they infiltrate the target site where there is an antigen exposure. And this influx of eosinophils leads to release of multiple cytokines. That leads to expansion of TS2 type cells, and that leads to a cascade of inflammatory response, and that leads to damage to esophageal mucosa or esophageal dysfunction. As I said, that there's an environmental main risk factor. There is genetic susceptibility, and there are a number of genes have been identified which predispose an individual to esophageal esophagitis, and all these leads to this disorder. Furthermore, there are certain risk factors like early use of antibiotic in childhood, preterm birth, and those who had a birth by cesarean section are found to have high risk for EOE, and those who have been smoking in early part of life, they are found to be protective. So if you look at what really happens in tissue, so once the eosinophils are there, eosinophils secretes a lot of cytokines, and these cytokines leads to multiple functions, and that ultimately leads to damage to esophageal mucosa. Coming first, that TGF-beta will lead to proliferation and hyperplasia of esophageal muscle cells. That leads to smooth muscle hypertrophy, which adds to stricture formation and dysmotility. It leads to damage to epithelial layer. There's a basal zone hyperplasia, and that leads to thickening of or lumen narrowing. It leads to vascular proliferation, and it also leads to activation and proliferation of extracellular matrix. And all of these together leads to esophageal dysfunction and ultimately esophageal stricture if the damage process continues. If you know this cascade of events, if we don't remove the pathogenic factor, the disease will keep progressing. And therefore, eosinophilic esophagitis is a progressive disease. And with time, the disease will progress and ultimately lead to esophageal stricture in majority of patients. So how this disease develop? There are multiple phases, and we call that three important phases. First phase is the phase of inflammation, where there is a cytokines, where the eosinophil infiltrate the esophageal mucosa and lead to cytokine release, and that leads to inflammation in the esophageal mucosa, and there is a there will be loss of vascular pattern out here. There will be edema here. There could be furrows. There could be, and once inflammation persists or continues, the fibrosis starts. That time you can find multiple other manifestations of esophageal disorder, and ultimately there will be fibrosis and will ultimately result into stricture of the esophageal lumen. And if you convert into symptoms, so in early part, when the stage of only inflammation, the patient may be totally asymptomatic or may have only mild symptom, and we cannot suspect eosinophilic esophagitis in those patients. And if you do endoscopy, you find normal endoscopy in them. There may not be any feature. There may be just mild erythema or some edema of the mucosa. But as disease progresses and leads to inflammation and fibrosis, that time you find number of classical features of eosinophilic esophagitis, and ultimately that leads to remodeling of esophagus and fibrosis, leading to stricture. And we'll come back to this, what will be the symptom in them and what will be the finding morphologically in these patients. Further on, as I said, that the natural history of EOE is generally is progressive, and there are three stages: that is inflammatory stage, inflammatory and fibrotic stage, and fibrotic stage. Three stages you find in early part of life, is most of them are either inflammatory or inflammatory fibrotic. But as you go along, as the disease progresses, or is the delay in diagnosis, majority of these patients which are inflammatory, they become fibrotic in nature. They become fibrotic nature. You find these are fibrotic, and you look, number proportion having fibrotic at early age is much less. So very important to recognize, like inflammatory bowel disease, eosinophilic esophagitis is also a progressive disease. If you don't treat them actively and effectively, then this process of a inflammatory stage goes to a stage of fibrosis and ultimately lead to esophageal stricture. So therefore, in early part of life, the symptom may be more or less non-specific. Like the child will reject food, they may have vomiting. If they have recurrent vomiting, they can have growth retardation. So early part of life, the symptoms are not so classical. And in these patients, you need to suspect this disorder, do endoscopy, do biopsy, and confirm diagnosis and treat them. As disease progresses, as length of disease progresses, there will be compromise in the esophageal lumen. Therefore, they can have more classical features, which are seen in high age groups. Like they can have dysphagia, they can have food infection, and they can have other esophageal symptoms. Meaning simply thereby that in early part of disease, the symptoms are less classical. We need to suspect, investigate, and diagnose. But as disease advances, the symptoms are more classical. They will have dysphagia. Dysphagia means esophageal disorder. It means one will do endoscopy just like that before dysphagia, and you find there is a, if you take biopsy, you find there is a disorder. Therefore, in early part of life, symptoms are less remarkable. They're remarkable, but they're less diagnostic. And in later part of the symptoms are more diagnostic. Since as I said, in early part of life, symptoms are not diagnostic. Therefore, there's always a diagnostic delay. We don't think of this disorder because diagnosis is based upon only on histology. Therefore, we don't think of this disorder. And this is one of the good studies from Switzerland, where in a large cohort of patients of almost 200 patients, it was observed that diagnosis delay is more than 6 years. varying from 2 to 12 years. And what is the effect of that? What is the effect? The effect is that those who had a delay of 0 to 2 years, only 17% had esophageal stricture. But diagnosis was delayed by up to 20 years, then majority of patients had stricture. The point I'm going to make again here is that suspect this disease, make early diagnosis, treat effectively. Question, how do I pick up a disease once features not classical? There's a high degree of suspicion. And that's the most important in making an early diagnosis. And another important thing, habit of taking biopsy. Somebody has esophageal symptom. The endoscopy is normal. Normally pull out the scope, we do nothing. We don't take biopsies. But if we have a habit of taking biopsy, we can diagnose some more additional lesion. Even the endoscopy is normal. We also know that esophageal lumen is about 3 to 4 centimeter in transverse diameter and about 2 to 3 centimeter in AP diameter. And dysphagia will occur only once diameter goes down to less than 1.5 centimeter. It means till then, they may not be in esophageal symptom, where we can suspect esophageal disorder. It's very important to remember this fact. Furthermore, somebody has esophageal disorder and they find difficulty in swallowing. Most patients adapt to different forms. They adapt to different forms, and what they do, they change their food habit. They avoid food that cause dysphagia, or they modify the way they eat. Like they chew food properly, they eat slowly, they lubricate foods, when drink a lot of water along with food. They won't complain to us that they have dysphagia or they're difficulty in swallowing. They modify their diet. And this is how most patients adapt to esophageal dysfunction in early part of disease, be it makhariA, be it esophageal cancer, or be it esophageal cystitis. In all of these patients, before they come to us, they adapt to the compromised esophageal lumen by changing their diet. Therefore, it's good to ask this question: that have you changed your diet? And ask this question. In any change in habit, the family can tell us that if any of these is happening, you can suspect esophageal dysfunction. Therefore, there's a dysphagia symptom questionnaire. What we ask in a collegia for advanced symptom, but again, for early symptom, you can ask this question: did you eat solid food since waking up in the morning? Yes or no? Since morning, has the food gone down slowly or gotten stuck in your throat? Or did you drink a lot of water along with it? Kind of this question one can ask and find out that if there is a esophageal dysfunction. So there are a number of barriers in diagnosis. In office, why is common in our country? Why is it uncommon in our country? Because we don't think of it. There are two reasons for that. One, that we believe there's no published report. We ask for evidence. Where's the evidence? Where's the evidence that this disease occurs in our country? Because none of us have really investigated disorder in our country. There are not any great published report from our country. There's no reason to believe that this disease is uncommon in our country. Lack of evidence does not mean there's lack of disease. And I point to highlight to everyone that lack of evidence does not mean lack of disease. This happened with IBD in our country 20 years back. We thought IBD is uncommon. Now find IBD is not uncommon. It's common in our country. So for many other disorders. So we don't think about this disorder and we keep very high threshold for making a diagnosis. I want to see esophageal rings before I think of EOE. The picture in mind is there that EOE means esophageal rings, which occur in only some number of patients, will not occur in all patients. Therefore, we keep very high threshold. High threshold, you are going to miss diagnosis, and you are going to make diagnosis only in the stage where the disease is more classical, more advanced. More classical, more advanced disease is easy to make a diagnosis, but hard to treat them. We just palliate. all disorders in whom we diagnose disease later, in later part of their disease course, we just palliate them. We don't correct the disease process. And second, that if you send a esophageal biopsy without writing that we are suspecting esophageal eosinophilia or eosinophilic esophagitis, then pathologists will not see this biopsy very carefully and they will not report. So they will always have a dialogue with pathologists to make this diagnosis. So when do I suspect? The most important is that I will always keep a high degree of suspicion, or I keep a low threshold for suspicion of this diagnosis. Patient may come as a classical symptom like dysphagia. They come with symptoms of esophageal dysfunction or heartburn or chest discomfort, like symptoms of GERD. They can come at they are doing endoscopy for some reason and you find, okay, there's multiple furrows in endoscopy. There are multiple rings-like lesions in endoscopy, or sometimes a good pathologist can give you a diagnosis on pathology without having this suspicion. But most important, think of this disease, make an effort to take biopsy if you do endoscopy in such patients. So what are the lesions? What are the lesions? Most people think that that the lesions has to be rings or furrows because this is what imprint is there in the mind. No. Many of patients can have a normal endoscopy. 17% patients can have a normal endoscopy. They can have lesions like white exudates. They can have a edema, therefore there's a decreased vascularity of the mucosa. They can have rings, which are so classical, and there's an imprint on our mind that once somebody sees this like lesion, will always say, okay, this is eosinophilic esophagitis, likely. If you have longitudinal furrows, like this, or you have food bolus impaction, as the patient I showed to you, or more classical, very classical ring-like lesions. This is the most classical, most easy to diagnose, but our ability should not be limited to diagnose the disease once we find this kind of lesion. Our ability to diagnose disease once see lesions like this and suspect, we cannot say this is esophageal esophagitis. This can occur in a number of conditions. Therefore, if you take biopsy from these, we can make a diagnosis. And this is one of the classical picture described. You don't have experience seeing this picture. It's called crepe paper mucosa. It looks like as you put your scope, the mucosa breaks like a crepe paper. And if you take biopsy from this, you find gritty feeling in taking biopsies. So this is what it also said is classical part of esophageal esophagitis or esophageal esophagitis. I want to make another important point, and just to highlight again, that if you look at endoscopic lesions, if we have rings or strictures, you could think of eosinophilic esophagitis, but many patients can have a normal mucosa. They can have only erythema. They can have only plaque-like lesion, where you cannot think. And if you look at both in adults and children, so as disease progresses, the strictures are more common in adults compared to children. So more advanced lesions are seen in high age group compared to children. Children may have a less advanced lesions, and one should keep that in back of our mind. And again, based upon the classical features, the endoscopic severity score have been devised. And one should remember, while we look at this severity score before and after treatment. If you have barium, you can see these rings-like lesions in the barium swallow. We don't do barium swallow for such patients, but if you do, you may find these kind of lesions, and you find a narrow esophagus. You find esophagus lumen has a really constricted. The key is, or the hallmark of this disorder is taking biopsy, because this disorder is diagnosed based on biopsy. Therefore, once you think of, even there's early lesions, you must take multiple biopsies, both from proximal and distal esophagus. We take 5 centimeters of a G junction, and again, above 5 centimeters, above that, we take biopsies. If you take more biopsy, the chance of making diagnosis becomes higher. And if you take more than 8 biopsies, almost majority patient can be diagnosed. Therefore, you take multiple biopsies, both from lower part of esophagus and upper part of esophagus. And please write on the request form to pathologists that we are suspecting eosinophilic esophagitis. Please look for this. And diagnosis is more than 15 eosinophils per high power field. And I said that eosinophils are not there in normal esophagus. Again, this picture I showed you earlier, that you find in one high power field there, you find multiple eosinophils, and sometimes eosinophils come joined together to form a eosinophilic abscess. You find multiple eosinophils here forming an abscess. Eosinophilic esophagitis is, eosinophils are not seen only in EOE. They are seen also in GERD. And we know GERD is a much more common problem than eosinophilic esophagitis. 10% of our population has GERD. Every 10th person in our country has GERD. And so therefore, we have in our country has a large number of patients with GERD. And if you do biopsy in them, you'll find they are eosinophils. So how do we diagnose? Is it GERD related with eosinophilia, or it is a disorder? Earlier, it was required that before we say eosinophilic esophagitis, you must treat PPI for at least 8 weeks and only then make a diagnosis. So this criteria was revised about 4 years back. And we'll come back to it in a minute time. Please remember that patients with GERD will have eosinophilia. And this was done almost 4 years back because the picture of both of them, that one condition defined PPI responsive eosinophilic esophagitis. There are patients with eosinophilic esophagitis with response to PPI. And they can have a similar picture like eosinophilic esophagitis. So these two cannot be differentiated. Therefore, the criteria of 8 weeks of PPI before making a diagnosis was removed from the criteria for EOE. And the PPI has become a treatment part of eosinophilic esophagitis. So how do we make a diagnosis? Diagnosis hallmark is that if you think of this condition, again, how do I think? High degree of suspicion, or if you have a classical lesion, you do biopsy. On biopsy, you find more than 15 eosinophils per high power field, or more than 60 per millimeter square of biopsy. You can make a diagnosis of eosinophilic esophagitis. It has been seen that the patient may have a symptom of esophagus. They can have multiple atopic conditions. And one need to keep in mind, do they have any other explanation for high eosinophil count in the esophagus? And you rule out these conditions. Think, and if there are any specific, then rule them out. This patient will also have peripheral eosinophilia. Why they will have peripheral eosinophilia? Because, as I said, there is an aero allergen or there is a food allergen. So the esophageal mucosa is exposed to food allergen. Therefore, local esophageal mucosa secretes chemoattractant. These chemoattractants go to bone marrow. From there, eosinophils are moved from bone marrow through circulation to esophagus. Therefore, bone marrow to esophagus, as they circulate through peripheral blood. Therefore, we find peripheral eosinophilia in them. About half of them may have peripheral eosinophilia, not everyone. So these conditions, these patients can have a peripheral eosinophilia. They can also have a raised IgE levels. They can have other part of GI tract involved. This is important to understand that if it is only, we really don't know that those patients have only esophageal esophagitis or eosinophilic esophagitis, their colon don't have eosinophilic counts high. So many of these patients can also have a multiple part of GI tract affected in them. And majority of them, about 2/3 of them, or half to 2/3 of patients do have some kind of atopy. Either they have allergic rhinitis or they have asthma. So in those GERD patients, as I said earlier, if they have features of atopy, or if they have not responded to PPI, think of eosinophilic esophagitis. So how do we treat these patients? Again, what the goal of, how do you treat? So what will be our goal? First goal of any disease is alter the progression of disease. But this part will change the disease natural history. And this is a most important part to my mind. And this is done by removing the etiological factor. You reduce inflammation by giving immunosuppressive therapy. And if there is an end result into dysphagia, then you treat dysphagia by esophageal dilatation. So you remove the etiological factor if you know, for example, celiac disease, gluten-free diet, tuberculosis, treatment of mycobacterium tuberculosis by giving antitubercular therapy, or here in most patients with eosinophilic esophagitis, the factor is food antigen. Therefore, removing those food antigen will decrease or will eradicate the disease process. If we can do that, reduce inflammation so that the progression does not happen as we happen in IBD, and also treat dysphagia. Therefore, three forms of treatment. The etiological factor is diet, the food antigen. Therefore, you have either elemental diet. What is elemental diet? You give the pre-digested food to these individuals. Therefore, they're not exposed to any kind of allergen. Or you eliminate diet. Some diet you eliminate. Right? We'll come back to that in a minute time. Then you give drugs. Drugs are either PPIs, steroids, or many other investigational drugs. And or if there is a esophageal narrowing, then you do dilatation. Now coming to what are the evidences of each of these therapy. And I would urge that if you can go over this article published in Gastrointestinal last year, is the AGA guidelines for eosinophilic esophagitis in 2020. It's a wonderful article to go through. It's a wonderful article. And it will teach us multiple things that how the evidences for a particular therapy are graded, how the evidences are accumulated and analyzed. So looking at that, so I'm going to talk about this paper for all the treatment responses, or what are the evidences. This is summary of evidences of this disease, the various drugs which we use in this disease. Summary of evidences I have taken from this wonderful paper, which is a guidelines by a group of experts on this disease. And for all trials or observable studies have one endpoint, that histological remission, that the outcome is less than 15 eosinophils per high power field. High to less than 15 is the outcome for each. So let's look at what is evidence for PPI in patients with eosinophilic esophagitis compared to placebo. 23 trials, and risk reduction is about 34%. The relative risk is about 66. Risk reduction is 34. And how do we understand this 34? Suppose if you have 1,000 patients, if I use placebo, then 867 will show a response. Of 1,000, with placebo also, we'll have 867 will fail to respond. 867 will fail to respond, means only 130 patients will respond, show response. But if you give PPI, compared to placebo, almost 300 more patients will have show response. Am I clear? That risk reduction is 34% compared to placebo. And if you treat 1,000 patients, 867 will have persistent disease. And if you give PPI, the 300 patient will show response compared to placebo. And why PPI works? PPI has certainly reduced acid, but it also have an anti-inflammatory effect. It also has anti-fibrogenic properties. Therefore, PPI has been shown to be effective in those patients who have eosinophilic esophagitis. Second line, if you can do that, if you can use PPI, then steroids. And Steroid therapy is given topically, and most of the data has come from children. There only few studies have come from adults, and most studies, the data has come from studies on children patients with eosinophilic esophagitis. The multiple preparations are available. That's multiple drugs available. This is you can give a fluticasone, which can be swallowed, or you can. There are also drug available, budesonide in the form of viscous, and one can give in. But once remember that one should not eat within 30 minutes of taking these drugs. And what's some of evidence from again AJ guidelines that if you use this topical steroid, 61% patient will have a remission. And again, if you want to take in numbers, 1,000 patients, if you use placebo, 880 will have no response. And if you use a topical steroid, 500 patients additional will show response to topical steroids. One must remember that topical steroid side effects are not high, but they can develop candidiasis in 5 to 30% of patients. Therefore, these patients are asked to rinse their mouth half an hour after taking this drug, and this is important. One also need to use systemic steroids. The data for that is only very limited, and this also believed that this should be more effective, but this drug has not been used much. There's only one clinical trial, and in compared to topical steroid and in compared to topical steroid, there is no difference in the efficacy of these two, either topical or systemic, but side effects were more with the oral or systemic corticosteroids. Coming to mainstay, because we know this is because of food allergen, therefore you remove the whole food. You feed them by giving elemental diet. It means giving them elemental. You give them carbohydrate, give them carbohydrate. They give them monomers of carbohydrate. They give them amino acids as a treatment, and therefore they're not exposed to any kind of food allergen. But question is that giving elemental diet is a difficult therapy, because to maintain on patient on elemental diet is very challenging. It has very high efficacy, almost 90%. So if you look at the data from AGA, if you use elemental diet, almost everyone responds, almost everyone. Response rate or failure to response is only 6%. Most patient responds to elemental diet. And if you can't do elemental diet, then the other measure is to give 6 food. And the 6 food which are important, the most common allergens are these 6 food. What are these 6 food? Wheat, nuts and peanuts, soya, fish and seafood, eggs and dairy. Again, to remember, wheat, nuts and peanuts, soya, fish, eggs, and dairy product. If you remove these 6 food, the response rate, I'll come back. Then comes 4 food groups. Rather than 6, do 4, wheat, soya, eggs, or dairy. And they also regimen that they remove only 2 food products, so wheat and dairy, because they are the most common allergens which leads to eosinophilic esophagitis. So you either do 2 food elimination, do 4 food elimination, or do 6 food elimination in these patients. And what the data for that? Looking first at the 6 food elimination, almost 62% patient response, right? If you look at 4 food, 43% patients respond. And lastly, we come back to so they are mainstay therapy, PPI, topical steroid, and systemic steroids. And in those patients where there's a clinical stricture and dysphagia, you do dilatation of esophagus, either using bougie or balloon. But remember, this is just a palliation. This will not reduce inflammation. The therapy of inflammation has to continue. Means these patients will require steroids or elimination diet as a line of therapy in these patients. So these patients, rather than only giving dilatation, you must continue drug which can reduce inflammation or eliminate inflammation in them. And almost half of patients require dilatation. If you do dilatation, almost 95% will have response in dysphagia. But remember, this is only a palliation. They will only improve dysphagia, but we need to continue anti-inflammatory therapy in this patient in order to stop progression of disease. So look at all of these, come to summary of these, what is the rate of remission in each patient, each treatment. PPI, 34%. Steroid, topical steroid, 61%. Elemental diet, 95%, but most difficult to follow. 6-food elimination diet, 62%, and dilatation, certainly 95, but this is a palliation. So how do you choose therapy? We have so much of choice. How do you choose therapy? The most classical, as I said, the most valuable treatment is elemental diet. But again, elemental diet is difficult to do. Again, I want to highlight, once you prescribe diet, always involve a dietitian. Most clinicians will not have enough idea about diet, they therefore always involve a dietitian. Look at feasibility. Can you use dietary therapy in these patients? In those patients who have PPI experience, so first line will be PPI. If they have PPI experience, then you can use topical steroids. But if they are advanced lesion, if there's a stricture, furrows, then although there's no data, I would believe that I will use systemic steroid in them because this is more effective and time is less because we already have a stage of stricture. We don't want to spend more time gaining the anti-inflammatory response. Therefore, you would like to use a more stronger treatment for these subjects. I think I'm crossing my time, but I'm going to close in next 2 or 3 minutes time. So all these patients will require maintenance therapy. And maintenance therapy is the therapy to which they responded. The long-term maintenance therapy is the most important, that is, you can do elimination diet, either 6-food or 4-food or 2-food. 2-food is probably most important. Avoiding wheat and dairy is the probably most effective long-term treatment of these patients. We don't have much data on maintenance treatment, and there's only one study where those patients who responded were continued on topical steroid, and these patients have shown not much of a response. There's no, the risk ratio is 0.7, but again, it's crossing the value of 1. Therefore, this is not significant. Nevertheless, most patients will require a maintenance therapy. And we know this is a very low degree of low level of evidence because there's no studies on this subject. But we believe, and we should believe, that most patients with EU will require maintenance treatment. Those who don't respond to ever-mentioned treatment, the number of other cytokine-based therapy are under investigation, but none of them are available for clinical use at this point of time. A couple of words about lymphocytic esophagitis. We define this term, we cannot suspect this disease clinically. There's no way, what symptom, when do we suspect this disease? We are not sure about it. But this disease is defined if you do esophageal biopsy, you find more than 20 lymphocytes per high power field in the absence of granulocytes. This is important, that you have only lymphocytic predominance esophagitis, it's called lymphocytic esophagitis. And you can find multiple eosinophils out here in the esophageal mucosa. This can occur in multiple conditions like IBD, celiac disease, and multiple motor disorders. The clinical significance of this disease is not well established, and the clinical significance is not very clear. But the picture of this may mimic exactly like eosinophilic esophagitis. Therefore, pathologists should also look on histology if there are any high lymphocyte count in them. Coming to summary, so how do you treat eosinophilic esophagitis? Coming back first to the patient we treated, we give this person systemic steroid for 4 weeks, and he is now maintained on azathioprine, and this patient is doing better. Coming to suspect a disease, confirm diagnosis by pathology, 3 options: topical steroid, proton pump inhibitors, elimination diet. One can choose any of these therapy. Elephant diet is the wonderful thing to do. The most effective is elemental diet, but it's hard to follow for long term. We do 6 food elimination or 4 food elimination and look for response. One can use proton pump inhibitors or one can use topical steroids in these patients. Look for histological response. If there's no response, then try alternative treatment. If you started elephant diet, you'd give topical steroid or vice versa. Maintain for long term, probably use the same drug or same therapy to maintain by which you have achieved remission. And if
it's 9 o'clock.
Do dilatation therapy in them. Remember, PPI, once we use double dose here. We don't use single dose, we do double dose for at least 8 weeks. So what are the highlights? Detect early. High degree of suspicion is the key word in eosinophilic esophagitis. We must think of this disorder and make effort to make a biopsy, talk with pathologists for the diagnosis, and treat them effectively. Efficacy, most effective is elemental diet. Topical steroid is effective in 61%, 6 food elimination in 62%, and PPI in 34%. Thank you for your attention.
Thank you so much, Govindji. We are really delighted. I also learned a lot. And since our moderator